Welcome to the Dutch Podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jacqueline Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. The information is not to be interpreted as or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, or treatment.
I'm so excited to dive into this week's episode on the Dutch Podcast, where we are going to talk all about GLP-1 agonist medications. Now, I know that these are a hot topic. Many of you are prescribing them. Many of you are begging your doctors for them. And really, they're showing to have a lot of promise. They're approved for obesity, type 2 diabetes, metabolic syndrome. However, what we're seeing is that there's a lot of applications that may go even broader than that we're seeing in published research. So today's guest is someone who's spent a lot of time. She treats women's health and really has spent a ton of time looking at GLP-1s and how they affect women in particular. In fact, her research was selected to be presented at the AAMP this summer. We're just going to be teaching all about this topic. So we have a wonderful guest today. You are going to love learning about all the nuances of how GLP-1 medications might be able to help women in your practice and what we really see coming down the pipeline. We talk about dosing, we talk about side effects, who is a good candidate and not. You're going to walk out of here with so much great information. Today's guest is Dr. Brittany Schamerhorn. Dr. Schamerhorn is a licensed naturopathic doctor. She practices in Kelowna, British Columbia. She's also a Menopause Society certified practitioner. And like I said, her whole practice is women's health. She's so bright and a really wonderful doctor. She has extensive clinical experience in women's hormonal health, supports patients through all stages of life, from PMS to fertility to thriving through and beyond the menopause transition. We're really lucky to have her with us today to get a little sneak peek of what she's been putting together for research when it comes to this AAMP talk. Well, thank you so much for joining me, Dr. Schamerhorn. It's awesome to have you here on the podcast.
I'm excited to be here. Thanks for having me.
Now, I'm thrilled because we're going to be talking about something that is obviously all over the media. Everyone's talking about it. Everyone's using these new medications. And, as a practitioner who's really focused on women's health, you've prescribed these, you've seen women on them. And I really want to dive into your experience and what you've learned and what the literature says. Yeah. But before we get into that, can you just share a little bit about yourself and your backstory? I love hearing how people got into naturopathic medicine.
Yeah, I feel like I started like a lot of NDs might have when I was going the route to medical school. I always knew I wanted to be in healthcare. I loved the sciences, so that was just a really easy transition in post-secondary. And then all of a sudden, I don't know why I chose this, but I was doing a biomedical degree with like a biochemistry degree with a focus in medicine. So it was like there's 5 people doing this because that was not a very popular degree. And I looked around and everyone was going quote unquote to medical school. And I was like, this is not like my community. This is not my vibe. And I was going through my own stuff at the time. And I terrified my parents and said I was not finishing my degree. I'm going to just take courses I like, which is what a concept. And it was in my nutrition course that I took. And they were like, where can you get nutrition advice? And someone brought up naturopathic medicine, and it was like this light bulb went off, and I was like, that's it. I get to learn the healthcare stuff. I get to work in this patient-centric model, but like evidence-based, and I could really just bring both worlds together. And it was sort of like that light bulb moment, and just there was no turning back. And I just kind of kept going from that point on. And which I appreciate, is because there was never a moment where I was like, did I make the right call? And I have loved it ever since.
That's awesome. I mean, it's interesting because I have teenagers now too. And sometimes it can feel so overwhelming to know what you want to do with your life. I love that you're like, I'm just going to take classes that I like, because sometimes it's like, what's your passion today? And if you can just keep doing that, you'll find your path.
And in all honesty, it was partially so I could keep the extended health benefits, because you had to take so many courses. So I was like, okay, I need to take 3 courses. I will take 3 courses I like while I kind of figure out what I want to do. And thankfully, that was very productive.
That's awesome. Well, we're all glad that you became an ND because you've been able to help so many women since opening your practice.
Mhm.
So today, really we're going to dive into the whole world of GLP-1 receptor agonists and women's health. But to start us off, can you share a little bit about what is GLP-1? Like, we have endogenous GLP-1? What do
Mhm.
we know about that? What do we know about these medications?
Yeah, I think we are just on the cusp of like this style of medication, right? So specifically, like we'll talk about the GLP-1s today, but this style of using peptide therapy, we're just on the cusp of it, especially when we're talking about its role in weight management and
Mm.
diabetes, et cetera. But GLP-1, it does, so glucagon like peptide 1, it does naturally occur in the body in response to food. Generally, what's interesting, it's in response to foods that we aren't often eating. So more bitter foods, things that are not part of that standard conventional diet. And what it does naturally occur when we eat those foods. But the problem is that one, many people, for whatever reason, don't make as much, or we're not having the diet that's going to lead to the endogenous GLP-1 production. And it can be super helpful because the role of GLP-1 is that you eat your food and then you have insulin that comes in to take the glucose down, and then it tells you that you're full, so because you've eaten your food, and it's all the communication that happens secondary to the response of eating food. But it's just that for people that are not secreting as much, then they eat their food and they don't have this feedback.
Mm. Are there things that can influence that, like why people don't get as much GLP-1 production
Uh,
than other people?
Yeah, I do. So there's a lot. There's genetic wise, I think is a huge component too, and also I would say downstream of like stress, the hormones, all of that. And
Mm.
then I also think we're just on the cusp of understanding how those roles are played too, and what changes the influence of that. Like if you don't eat bitter foods, you don't promote as much GLP-1. So if you go to McDonald's and get a burger, you're not going to have the same GLP-1 production as if you eat an arugula salad.
Yeah, that
So
makes
there's
sense.
multiple components in there.
We need more arugula and dandelion greens.
Yes.
Yes. So let's talk a little bit about how these are used conventionally in practice. What are the main indications? What are they FDA approved? Well, you're
Yeah.
in Canada, but Health Canada approved for and FDA approved for. What are we seeing as far as when they're prescribed?
So the two most common, they both initially came out for diabetes, so type 2 diabetes specifically. And then they discovered that we saw weight loss independent of diabetes. So now they've been approved for so obesity and weight management as well. I don't know if it's gone through yet or if it's going to go through, but there's a sleep apnea approval right now. And
Cool.
that connection with weight is where it's coming from, right? And then there's also something downstream for secondary cardiovascular prevention as well. So if someone has an MI, they'll leave the hospital with like the list of medications, and the GLP-1 would be in there as well. So, or something along that line. But the main one is where I'll see most conventional doctors, or if you're just starting it, is going to be the diabetes. That's really the strongest. Some people were still seeing that hesitation around using it for weight management, but it is approved, and that is a good use for it too.
Okay. So, but now I know it's also being like suggested to be used for a lot of other broader indications, like across metabolic health, hormone regulation, inflammation. Can you share a little bit about what you've learned about kind of broader applications? Of course, these are not ones that are approved, but
Yeah.
I know I certainly hear a lot of providers talking about it.
Totally. And I think one comes from its insulin component, right? And we know that it helps to regulate insulin. And it's really interesting because if we think about this, the functional world has known forever how potent insulin resistance can be and the role that insulin can play on so many different diseases and conditions. And that's where we're seeing this impact, right? So autoimmune conditions, we're seeing the improvement in inflammation. And yes, these medications can actually decrease inflammation themselves, but then they also, through their insulin resist, like improving their insulin regulation, they're
Mm,
also having the secondary side effect. We have that cardiovascular prevention as well. I think a big component is the insulin and the inflammation, those two.
okay. So, I mean, I know a lot of our listeners are providers, but some people are not. And I think they're surprised to hear that naturopathic doctors can prescribe
Mhm.
still,
Yeah.
depending upon where they practice. You can, obviously. I can in the states where I practice as well. So, but this is an interesting conundrum. So, I want to talk about like where do GLP-1s fit in to the naturopathic perspective and the therapeutic order, because I think that there is, let's just say, diverse opinions around whether we should be prescribing GLP-1s, because of course we want people to start with food and exercise and those lifestyle mechanics. And then on the flip side, if you have patients who have these really huge risk factors due to obesity, metabolic syndrome, et cetera, maybe those are the places where medications do fit in, at least temporarily. But can you share your point of view? Because I'm sure you've thought a lot about this, and I think most of us do. You wrestle with it, like quick fix medication versus lifestyle fix, which of course we all would view as the gold standard.
Absolutely. And I'll often think to myself, what if I give this medication, what becomes accessible for this patient? And a lot of if we think about any medication, we ultimately want it to improve something in their life, right? That's why we're giving it to them. And if we give someone who's struggling with their weight a medication that's going to help with their weight, they're now going to be able to move easier because they're literally having less mass on them. They're also seeing that those scales going down if they actually do go for that 10-minute walk. So they're more motivated to keep going. And so it's sometimes these medications are the buy-in to the lifestyle component. And we all need some dopamine. So let's take it away from TikTok and put it back into our food and our exercise. And it's actually just letting them get what can they access if we give them this support. And it's also just decreasing that stress, that load. We were raised with so much food noise, the diet culture, so many changing opinions, where I feel like that's really hard to unpack if you have without the support of the med sometimes. But I do agree, I do struggle with it, where it's sometimes I'm like, oh, is this the quote unquote the easy way? But I also, that depends on how the patient takes it or how it's prescribed. When I prescribe it, we are having regular touch point. And the magic is not the magic medication. The magic is in these lifestyle changes. It's in now them learning about what protein is, them learning about what fiber is, them learning how to stay full so that when their appetite has gone down, so now when they actually do eat, it better helps sustain their blood sugars because they need to feel good. And that lifestyle stuff is where the magic happens, for sure. It's not the med. The med just kind of opens them up to that.
Yeah, I've also seen where people don't have the same cravings. And so I don't know, one of the things that I think is an advantage is it helps people think about food as fuel versus food as an emotional soothing, because that craving piece can decline.
Yeah. Or they will think about where a lot of times it's I'm hungry for lunch. Okay, I want to have X, but I'm going to eat this because this is what I should eat, versus being okay, well, it's lunchtime. What would fuel me the most for the afternoon? They can just change how they can think about their food. I had a patient come back over Christmas and she was like, I have a bone to pick with you. And I was like, oh dear, what happened? And she was like, I was around my family. It was chaotic. So much was going on. And I went to the dessert table to eat my emotions and it didn't work. And I had to deal with my emotions. And it was because now she's like, one, I realized what I was doing. It didn't actually satisfy me. I didn't really want that food. So then I had to actually look at myself and have that conversation. And I do think people have the patients have to be open to that, right? And I'm sure it's the same in the States, that you can go online and get these medications so easily now. But if you really want to have that long-term change, I do think that these meds can make that accessible, not for the mental component as well.
Well, let's talk a little bit about some of the risks of the medications. And then I do want to dive in, and we're going to spend a lot of time today, for those of you who are listening, because I want you to stay through to the end, about how these GLP-1 agonist medications, and it's not just GLP-1s, there's other peptides as well, how they fit into women's health conditions specifically. We're going to talk about PCOS. We're going to talk about perimenopause and menopause. So hang tight here. But I think there are some legitimate criticisms. There are studies showing that people lose muscle mass on the medications, that there can be other limitations to the benefit. So, and things like you can never get off of them. How do you think about these, or how do you manage these? And how is that maybe different from the people who do go to an online, pharmacy mill? I don't know what you'd call it, or people who go to a conventional provider. How is it different when a naturopathic doctor recommends these medications?
I think the differences are full whole centered care, right? Where we look at the patient and they're sure they might come in for saying, I want to do XYZ, but most naturopathic doctors are not only doing that 10-minute initial, okay, here's your thing, that's it. It's the conversation around, okay, if you're going to take this medication, we need to be cognizant on your protein intake. Here's the goals that you need to do. Also, on a capacity standpoint of our practices, we usually have more options for follow up. Whereas at least here in Canada, we have such a family doctor shortage that they're getting the prescription and they're like, hey, I'll see you in 6 months. Just here, like they literally are just told to taper up as they need. And there's no direction on when they increase the medication. There's no like, and that is without that coaching, that's a huge piece that's missed. And we see this all over the research where any weight loss, the true magic is in the touch points in the coaching. Whether or not you have someone that does does some form of diet or whatever, it's the touch points where that is long term. And to tell where you talked about it being long term, I will always preface with my patients that the guidelines from the medications and from Health Canada is that these are long term medication uses, right? We're thinking like type 2 diabetes long term or that significant weight management. But where we're coming from as naturopathic providers is we're also trying to address what got them there. Right. And if we go back to what we were talking about before with how it works in naturopathic medicine is we are still doing the root cause. Like we're looking at the lifestyle stuff that got them there. I had a patient this week and she is like, I'm way too busy. I can't get a walk in. And I'm like, hey, well, you're not like that needs to change because this is the problem. Like you saying you're too busy to get your exercise in is what got us here. And so we're not going to talk about upping your med until we talk about how we get your walk in. And that I think it's just having those boundaries and that conversation with the patient about what this entails. It doesn't just entail, and I've seen the dark side of TikTok. I know we all have where, oh, I took the medication and now I can eat McDonald's and I lose weight. That's not why we're doing this. We're doing this for the bigger changes. And so people can actually readdress that relationship.
Yeah, it's a mindset
Mhm.
difference for sure. Like, I think that it will suppress your hunger and you could eat junk food and
Yeah.
eat less junk food and still lose weight because it's cutting your
And
caloric
of
intake.
course, those people are going to be the ones that lose muscle mass. And
Mhm.
I think that right now, at least in the research, we don't have enough to really pull out the people who got more coaching versus the people who did not, the people who just ate junk food but ate less junk food and lost weight versus the people who ate their protein. Like we just, and this is with any weight loss too, that I'll tell patients is if you lose weight, you're going to lose some muscle mass. How you lose the weight matters. We just kind of have a bit more weight loss with these meds.
Mm.
And it's just that emphasis on and pulling people to remember that we care about how they feel in the next 20 years.
Yeah,
Right. I
that's a
know.
great point. I wonder if there's any data out there just on comparative means of weight loss. I mean, obviously, diet and exercise would be your gold standard. If people are lifting weights, they're going to retain muscle mass. But I wonder, and there may be, maybe you know, or maybe not, like the data showing different types of supported or unsupported weight loss, like the
I
comparative
do
muscle mass
think there is
loss.
something that I read at some point where there's always muscle mass loss and there's always weight regain. So
Mhm.
whenever you quote unquote like stop your diet or you do whatever, and again, I think that's also we want to move away from the dietary part to more maintenance and lifestyle. But there's a 10% regain. So if someone lose 10 pounds, they're probably going to gain like 1 to 2 pounds. If you lose 100, you're going to gain like 10 to 20. Like I think so. It's also setting that expectation with patients that you're not going to hit your goal and that's it. Like you're still going to fluctuate. And then there is that we see muscle mass loss across the board. But I don't know if there's a difference depending on again, have we pulled it out to say how they lose it? Is it just caloric deficit? Yeah, of course they're going to lose more muscle mass than if they actually do the weight training too.
Mhm. Yeah.
Mhm.
Well, let's shift gears and talk a little bit about women
Mhm.
specifically. So, you've shared that there's a few indications in women where you think this has like a special niche. What are
Yeah.
those?
PCOS is a huge one. We know that insulin dysregulation plays a huge role in PCOS. So that's going to be a significant portion. And I haven't looked deep into the fertility part. And I think a lot of the fertility is connected with that PCOS, but I know there's more. I was just looking, there was like something with fertility and IVF on that coming out. And then we do have a lot with the menopause transition and these medications as well. I would say those are the the biggest areas that I'm seeing right now.
Well, let's talk about PCOS first. So
Mhm.
can you talk a little bit about, where GLP-1s fit in? Like, what's the physiology behind PCOS? Why is insulin so important for women with PCOS?
Yeah. So I was just reading a study which I found very interesting that they did, I think it was short. It was like 14 weeks of a GLP-1. I think it was like of a semaglutide. And they stopped it, and they actually then the testosterone was lower. So not only is it on the insulin resistance, but it also lowers the androgens. And what was really interesting was the androgen decrease stayed for 2 years after that medication.
Oh, cool.
Would like even without going back on it. And I was like, oh, and so we saw more cycle regularity. So it's addressing that insulin component, but also the androgen component there as well. So we're seeing that the cycles are coming back more consistently. That's a huge part, right? They're not having a period. So how are you going to get pregnant if you're not ovulating? Um, and then it's also just weight management is huge for PCOS, right? Like we have so many great meds for the symptoms of it. Like we can even use like inositol and like NAC or for if they have acne or the hair growth. But that weight has been that stubborn one where they'll be like, you have to do keto or you have to do et cetera. Like there hasn't been this like, and again, nothing's a silver bullet, but there hasn't been we can help the weight part of PCOS. And I do feel like there's a bit of a different picture in my PCOS specific patients that these medications are generally used at a higher dosage and we might be going to other versions of it, but it really helps.
And how long? I mean, when do you typically see improvements? And how do you combine it with other therapeutics that you might recommend?
So you can combine some of the GLP-1s with metformin.
Okay.
So you obviously want to make sure that you feel confident in that prescribing, but it's also like if we're talking about say the semaglutide versus the trizepatide, I do find that I have to use the trizepatide, which is the one that has the 2 peptides in it instead of the one for my PCOS patients, and they get more success than just on the semaglutide. It's almost like it's just more stubborn, and I think that's also where there's the weight loss from someone who just had poor lifestyle choices. And then there's the weight loss picture and the insulin picture from someone where there's like more of a genetic component and like a disease background. And that's going to be obesity, PCOS, et cetera. I find those disease-based patterns just need a bit more support, like more
Mhm.
behind it.
Yeah, it's interesting because it's like in the case of PCOS, you have your physiology like working against you. And I
Mhm.
really see that with patients with PCOS. They are doing everything right
Yes.
and still not seeing the needle move. And I just want to validate that because, I really believe my patients when they tell me how
Yes.
much they're exercising and what they're eating. And
Yes.
it is really tricky because you're right. There are genetic components that predispose to insulin dysregulation and insulin resistance that
And
can make it
I was
hard.
just recently listening to someone and they were talking about there's also the inability to deal with hunger. And there's certain like people that you cannot be hungry, and like just a little bit of hunger feels so much more significant to you than someone else who might not have that predisposition. And where just eat less, that's like such a harder reference point for someone that if they can actually handle a little bit of hunger and they don't feel like they're going to kill everyone next to them. Um but
Yeah,
yeah,
it's like
right,
how
and
much
that's the
leptin
piece.
and versus ghrelin you make and all the other,
Yeah.
hunger and hormone signals.
Yeah, but the PCOS, I think that's a huge, like, right, the weight, they'll do so much for the weight, and they are to like where it significantly impacts their mental health. And so just to be able to offer them this support where their effort is showing like we're
Mhm.
getting the results from it, it's huge.
Yeah. One thing that's really interesting that I've talked to a couple podcast guests about is that microbiome like also can play a role in GLP-1
Mhm.
production, right? Like Akkermansia has been shown which is a keystone strain in the gut that a lot of people don't have. And it's been really well researched because it was connected to people who tend to maintain more of a lean body type versus obese. And we now know that Akkermansia can contribute to production of GLP-1. So
Mhm.
that's another piece to think about for patients is what's going on in the gut
Which would
and
come back to what you're eating too, right?
comes
Like,
back
or
to
is
what you're
that gonna
eating.
be
Yep,
more likely to the patients who are eating the higher bitter foods, right? Does that
definitely.
And again, it takes a while for the taste buds to adapt. So if we give them these medications, are they now more likely to eat the arugula salad instead? And then we can get that microbiome change where now weight loss is more supported and they can keep their weight management down without the med. Like,
Mm-hmm. Yeah, great. So let's shift gears and talk a little bit about perimenopause
mhm.
and postmenopausal women as well. This is another group that you've identified that there's
Yeah.
benefits to considering GLP-1s for patients who are good candidates for that. Tell me more.
Yeah, it's not weight challenges in perimenopause is very common. And I know many women, it's like their top two concerns. Like I think they would probably put like their sleep and then their sleep, their brain fog, and their weight. Like it's almost like we're okay with dealing with hot flashes if those three are taken care of.
Mm.
Um, there's so many factors that contribute to the weight change in through the transition. There is more insulin resistance that happens there. And then there's also the impact of the symptoms of menopause. So if you're not sleeping well, that impacts your weight. The hot flashes, we have that cardiovascular component to it. The mood changes. So some of it is, are we gaining weight from the symptoms of perimenopause, or is it that we're gaining weight from like the hormone changes itself? Either way, GLP-1s can be a great support for these patients. And I find these are also the patients where that psychological component comes in because they grew up with like Weight Watchers and Atkins and like there was never education on how to fuel. Like they're learning what protein is for the first time and what fiber is. And the challenging part through this transition too is that we'll have the women that have been fine for their weight forever. I've done everything the same. If I need to lose so much, like 5 pounds, I can do this and then I'm good. And now it's not working because the hormone changes that happen make it so your metabolism does shift and they like don't know how to support themselves through that. And like GLP-1s are never the answer for a 5-pound weight loss, but for that bigger transition, because again, I feel like the weight changes in perimenopause can be subtle. And then all of a sudden someone's like, oh my God, I'm like 50 pounds heavier.
Mm-hmm.
And it was very slow. And now like, what am I going to do? And this is where that can be quite helpful. And it comes down to that insulin component because it does help with insulin regulation. And then I think for the lower, like I'll dose it generally a little bit lower in this population. It's the mental and just actually unpacking and learning about nutrition.
Great. And is there any evidence for using GLP-1s alongside HRT, or is that not really something that's been published on yet?
Yeah, there is. There was late last year, there was one study that showed that actually if you combine GLP-1s with hormone replacement therapy, we saw greater impact of the weight
Oh,
loss. So
interesting.
there was GLP-1s on them by themselves, we saw weight loss. And if we added GLP-1s to someone who was on hormone replacement therapy, they had more benefits. Whether or not that's because the hormones manage the symptoms, but we can absolutely use them together.
Mm-hmm. Okay, cool. I want to. Are any other women's health conditions that you want to highlight that you think there's
I'm sure. Well,
particular?
I think there's like the autoimmune, the cardio, like, and it all comes to the same root of decreasing inflammation, helping with the insulin resistance. And we know in functional medicine, naturopathic medicine, that a lot of that is the root of so many problems. And so it's just getting back to that root cause part.
Mm. Let's talk a little bit about the cardiovascular risk reduction. What does evidence show around GLP-1s and their ability to reduce potential cardiovascular disease or cardiovascular events?
Yeah, I think this is a great question because I wanted to. So I know in the naturopathic realm right now, there's really big, like microdosing the GLP-1s is quite big. When it comes to a lot of the evidence that we're seeing for, say, cardiovascular risk reduction, there's a certain dose associated with that. And I feel like it's important for us to know when we're using like, oh, if we use these, it helps with cardiovascular disease. We're actually talking about a like more therapeutic dose than this microdosing. And we don't quite have confidence to say that microdosing can give us that same support as the therapeutic dose.
Mm.
Because the dose is different, obviously, right?
Yeah.
But we do know that any weight loss is going to reduce cardiovascular disease. But on that point, we do know that the therapeutic dose of semaglutide specifically has shown to reduce cardiovascular risk outside of weight loss.
Yeah, I was going to ask that because can you tease it apart? Because it's like if you get weight loss reduction, or sorry, if you have weight loss, weight reduction, you are probably going to
Yeah.
experience improvement in your cardiovascular risk profile. But you're saying on top of that, the medication, maybe due to the anti-inflammatory
Yeah.
effects or something else. there's
So
additional benefit?
independently, so they saw that even if they did not lose weight, there was still a cardiovascular risk reduction.
Hmm.
Mhm.
Okay. And what other outcomes do they see? Are there any changes in like blood pressure, lipids,
Yeah, the
anything else
blood
that's
pressure
measurable?
generally goes down. And I think I don't know specifically if that was weight related or not. So we're going to see the lipids go down with the weight loss and all that as well. But in general, we see the blood pressure go down. We see an improvement on the lipid profile. We obviously see an improvement on the sugars. So the blood markers generally improve overall, which is also really cool because for patients that maybe don't want to step on a scale because they have some issues with that, then they can actually see these like blood markers on paper that they're seeing improvement in their risk factors.
Mm-hmm. And tell me a little bit more, because I think women really underestimate cardiovascular risk, but it is such a big cause of death for women in
Mhm.
midlife. We think of it more as a male problem, but thankfully, like I think now people are starting to talk about it more, but
Yeah.
it is a substantial risk for women as
It's our
well. That's
biggest risk factor.
worth
And
talking about.
unfortunately, the most common symptom of cardiovascular disease is death. Like that's huge. Like
Yeah, it is a silent killer, particularly for women, because they
yeah,
don't tend to get the same like angina symptoms as commonly as men do. That could be that early warning sign.
totally. And so I think it's one, this is like I said, but like it's testing and knowing your risk. And I think what's so beautiful about the like perimenopause and menopause movement is bringing attention to your health because there is the conversation around the hormones and their connection to your long-term risk factors, which is making people think about those as well. And
Mm,
so I'm personally seeing a lot more women advocate to see their risk factors being tested. And I think that is a really positive thing that's come out of that movement.
yeah, absolutely. Any other conditions that we need to cover as we talk about GLP-1s in women? Anything I've forgotten to ask you about there?
I don't think so. I feel like
Okay.
if there was fertility, you'd be the one I'd be asking you. So
Yeah, with fertility, it'll be interesting to see what studies show long term. I mean, I think the anti-inflammatory benefits
Mhm.
will come to bear fruit. And absolutely, we know the connection between obesity and infertility. I was actually just reading another study this morning um, on sperm health in men and its connection to
Yeah.
obesity. So certainly, if we can improve glucose regulation, you can reduce weight, reduce inflammation. We would expect to see
Yeah.
improvements in
I just
fertility
I feel like
outcomes.
we're on the cusp of like all of this research coming out with this because now we know where, right? We know where it's worked, and now we've seen also clinically and in some studies, oh, this also got better. So now we're
Yeah.
just teasing out that a bit more.
Yeah, I think you're right. And it's interesting because it's not, I mean, it kind of feels like right now it's like the cure for all ills, right? Where it's getting so positively talked about in the media that most people I talk with are like, where can I get some? And why wouldn't I be on it?
Yeah.
Even those people who have the 5 pounds to lose, right? And
Mhm.
I hear people in our own community talk about its use in people of healthy weight for some like autoimmune patients, for example, for
Mhm.
some of the other benefits. And I'm pretty cautious when it comes to applying something in a new way. It's great to have theoretical hypotheses,
Yeah.
but we don't want to use our own patients as test subjects
No,
for
and
this.
that absolutely not, especially when a lot of that we're playing with the dosing, but pulling from like the therapeutic dosing for research backing. And it's just we're learning a lot, and it's not to say it's not going to be helpful. And I'm super thankful for the people that put the time and the effort in the research so we can have the answers. But I agree. I'm like, there's so many other things that I know can help that I'm
Mm.
just going to wait until I got a bit more backing for some of that.
Yeah, I think that's a smart approach. So let's talk a little bit about some of the common side effects with these medications. I know, like I've had friends who've tried it, who were met the criteria for it, that had like terrible, terrible nausea. Sometimes it was tolerable, sometimes it was not. What are some of the side effects and the common risks?
Yeah, so the nausea is obviously a common one. I have nothing to back this, but I've actually started to ask, and my patients who had significant nausea during pregnancy have more nausea on the GLP-1s.
Oh, interesting.
So I just
Yeah.
kind of, if I ask them and then maybe I'll throw in a ginger and I just prep them. And what's great across the board with this medication for all side effects is dose dependent. So sometimes I'm starting even lower than the recommended starting dose because the side effects are so high. And it's tolerability. So you do build up a tolerance to the meds. So then you have less side effects over time. But The nausea and the heartburn are going to be the two most common that we see.
Mm.
The other ones that we can see a lot of is actually mental health. So I don't think it's commonly talked about, but it can occur where a woman we can like trigger depression.
Oh,
And it
interesting.
feels really, it can be hard to tease out if you're not aware that that can happen. The hard part is you also need to rule out, are they eating enough, right? Because
Mm.
now the beneficial side effects are the appetite suppression, the changes in your cravings. Like these are things of why we're taking the medication. But that can then lead to you're physically not getting enough protein. So your blood sugar is dropping and you're feeling more anxious. You just want to tease out, are they actually supporting their system right? And some of these side effects coming from them not actually fueling properly, or are these truly side effects?
How do you make sure of that? Let's talk a little bit about the way that you as a ND are kind of proactive. You keep talking about protein, protein, protein. So I have a feeling that
Yeah,
setting your protein target or having your patients track protein is probably part of the picture. What else?
totally. Yeah, I
What else?
will have there's before we ever talk about increasing a medication, the med, they have to kind of pass two criteria, is the fact of like, one, are they tolerating the med in the sense they don't have side effects? And two, are you able to hit your nutrition goals? And if one of those is not met, then we can't talk about increasing your medication yet. And it's so easy and clear for patients that they understand, even though beyond those two rules, there's much more, right? Because part of that nutrition goal is the fiber, like you said. It's also to make sure that they're eating throughout the day and not just having the protein, like you said, that they're not just having one meal.
Mhm.
I also really want to make sure that at the beginning, when someone starts the med and it works for them, they get really excited. And so they lean into some of the more where we get worried about the med of like, oh, not eating and
Right.
they don't focus on eating right. And I remind them that we do know that there's a tolerance with these meds. And so we do often have to increase the medication to have that same impact. So let's take advantage when it's at the lowest dose to really like train you what has protein, what doesn't. How do you make a smoothie in the morning? How do you fit a salad into your routine? How do you actually get your exercise going? Because a lot of this is actually patients taking time to do the prep.
Mm.
Honestly, the medication is the easiest part.
It is the easiest part, I agree. And I
It's
think it
the
can be
prep.
tricky. Like I think sometimes and I personally think that having people track their food is at least as a learning tool, not as a long-term piece. But when you start this medication, if you're seeing dramatic shifts in your hunger, I've had patients actually track, macronutrients and track their food with this, and then come to find out they're eating like 500 or 600
Yeah.
calories when they're eating to their hunger. That cannot be sustained.
No.
That really and also that can have a lot of negative repercussions, and I find that you're having to counsel patients to increase
Yeah.
their food intake, and sometimes that feels hard. So I know that what you're saying, you can lower the dose again to get less hunger suppression, but it really does have to be monitored, and I don't think that conventionally that's really done as much, and it makes me concerned about what happens to your metabolic rate when you are consuming really low amounts of calories for a long period of time.
So I will sometimes, if we have the ability, I will test their BMR. So using some form of machine medical
Like
equipment
DEXA or
or like an InBody or something
yeah,
like
embody,
that.
yep.
So we actually get their basal metabolic rate, and we can see that from when you started to from now, because you aren't maintaining your muscle mass because of this, we've actually lowered your BMR. And so now you have made it so that you have to actually be in that even lower caloric deficit than before. And so it's just pulling out that math of, okay, like we actually want to up this for you. Our
Mhm.
goal is to increase your BMR or maintain it the same. And being able to pull that data out and explain that to patients where because you're eating so little and you're actually not working out or you're not maintaining your muscle mass, that we've lost this. Our goal is to up that. And so giving almost like a different target instead of just the weight.
And what would that target be?
Like the basal metabolic rate,
Oh,
right? So
having them track BMR,
right, to
okay.
have them track that, or if we look at the
Mhm,
muscle mass, right?
mhm.
So or the fat percentage, something along those lines, instead of it just being the full weight. And I know that some people, we just have the scale and that's fine, but those are the numbers that I might lean on in that patient where I'm like, you're only having 500 calories a day. Like, and
Right,
like I'm sure you want to come off this med at some point, so that needs to
right.
change.
Right, right. So, I mean, generally, when we think about weight loss, you're looking at like a reduction in calories of like 300 to 500 calories a day
Mhm.
over time to
Mhm.
improve weight loss, but then not do it in such a manner that you're harming your
Yeah.
metabolic rate. So, I just as a point of reference for providers, if your patient's eating, 2,000 calories a day, they'd go down to 1,500. But you also, I think, generally, you don't want to go below 11 or 1,200. Like if you're below 1,200 calories for a woman, that's probably too low.
Yeah, absolutely. And I want it to be that you can have like 3 good meals.
Yeah,
Like, you
absolutely.
don't need to have one of them be like where, "Oh, I can only have my side salad," or like what you wanna be able to make it be 3 meals that they
Mhm.
can enjoy.
Yeah. Another challenge I see with that kind of hitting a caloric intake is for women who've been doing intermittent fasting, when you add a GLP-1, I don't know if you've seen this too, but there's like not enough time in the day to consume the calories that they
Yes.
need to eat. I don't know, have you seen that as well?
Oh, absolutely, and I intermittent fasting, I think, is really easy for some women because we're of our cortisol response in the morning, right? So we're busy. We suddenly gotta get the kids to school. We gotta get this going. And then like we're just amped and we have our coffee and we might have the second cup of coffee. And it's not that they're intermittent fasting, they're just really leaning on appetite suppression.
Hmm.
And so I'll have that conversation and they clue in like, "Oh, actually that's so true." Because then I get to work and it's like 10:30, 11, and everything's calmed down because work is often maybe less stressful in the morning at home. Then they're hungry. But if we
Mhm.
can just shift that where I'm like, "Hey, just have a smoothie or something in the morning." It takes I will say it takes time. I don't know if you've seen this where that appetite in the morning, it takes a little bit of time for them to actually get that hunger cue. But a lot of the times if someone thinks intermittent fasting was super easy in the morning and they naturally do it, as I tease that out more, it's usually that they are just leaning on appetite suppression.
Yeah, I see that a lot. It's like, oh, you're over caffeinating
Yeah.
and that's really helping to suppress your appetite. Or you are also just so busy at the start of the day that it kind of runs away from you. And both of those things are problematic.
And you don't we have a lot of women work out in the morning. And so now
Yes.
they're working out, not giving them the nutrition right after the workout. And like we miss a huge opportunity for improvement there.
Mhm. Okay, so we've talked about protein and good nutrition. What about any kind of supplements that you use when you're prescribing GLP-1s? Do you put women on
Yeah.
creatine or is there anything else that you're like, oh, I really should get?
I think every woman should just be on creatine anyway. So
I
yes,
kind of am feeling
absolutely.
that way too, actually.
Yeah.
That's what I'm drinking right here
Yeah.
is my
Perfect.
creatine.
I have actually this has been a new shift in my practice. I've been leaning more a lot to a multivitamin for them because as we're educating, then their appetite is changing. I feel like there is a really big retrain. Like you said, they'll skip a breakfast and we have to, or they're only getting 500 calories a day. And they're definitely not going to be getting all of their minerals and vitamins in at that point.
Mm,
So I have been using that a lot more in my practice because I just with that assumption that as we're retraining their nutrition. The creatine would be one, the protein powder, and then symptom management. So the ginger I find works quite
mm,
well for that nausea piece. To be honest, I find the nausea goes away pretty quick, and if they actually are eating balanced meals, it tends to be okay.
mhm.
Like those would be my go-tos.
Great. And the only other question I wanted to ask you was about microdosing. So
Mm,
I've seen that term thrown around a lot. You and I have even talked about this. There's like
yeah,
no clear
yeah.
definition of what that is. What is microdosing? Do you have any kind of explanation for people who might be in the same position where they're like, what is this? Is it
So
real?
from my understanding, so one, I'm gonna like, is it real? Is there anything from any regulatory body saying no? No regulatory body is referencing microdosing, has it in their guidelines, nothing. Does that mean it'll happen at some point? I don't know. But right now I'm gonna say it's not evidence-based real. Um from what I understand it just means below the therapeutic dose. And when we look at say semaglutide, the pens the starting dose is 0.25 and then you go to zero point 0.5 and then you go to 1. The therapeutic dose is considered 1 milligram. So when we're talking about say cardiovascular risk benefits, et cetera, we're looking at 1 milligram of semaglutide and upwards of 2.4. So that but the starting dose is 0.25. So there's a really big range, obviously, between 0.25 and 2.4. So what I tell my patients is it's just below this therapeutic dose. And from what I've been told from other NDs, that is pretty much what it is.
Mhm.
But
Yeah, the
that's
other piece I've heard is twice a week dosing rather than once, which
yeah.
actually, like, I think probably once a week dosing is, well, I mean, there's a half-life of the drug,
Mhm.
right? So it'll stay in the body that long. But it's like, well, how can you maximize the benefit with less injections? Because injections probably are a deterrent for
Yep.
people. However, I think if you're using a lower dose twice a week or half the dose twice a week, you may be able to sustain a more steady pharmacokinetic pattern in the
Yeah, because you
bloodstream. So
do get
theoretically,
that.
that makes sense to me. Less up and
Mhm.
downs.
Yeah, because I tell patients that you can time the medication, the injection, the once a week based on when your hardest time of the week is. So for a
Mm,
lot of people, the
like
weekends tend to be the
Fridays.
hardest. Exactly, the weekend. So we take the injection on Thursday because then you know you're going to have that impact for Friday night, Saturday, Sunday. Come Wednesday night, you might be like having those cravings kind of sneak in a little bit, but then you know you're good. The twice a week injections can also be very helpful for side effect control. So if we need to up the dose, but they can't handle it on that side effect profile for the nausea and the heartburn, sometimes doing the twice a week can be good for that.
That's great.
Mhm.
Well, that's helpful. And this has been hugely helpful as we explore a new topic and really like new applications of this, which I
Mhm.
think, like you said, this is not just a medication, it's like a whole class, a whole family of medications that I
And I
think we're
think
only
this
going
is
to see.
where NDs, like we shine here, right? We can really make these medications be more effective. We can make patients feel like they're learning, they actually understand what they're doing. And I like you said, it can be quite controversial, but I feel like this is a great spot for our profession. We know all about macronutrients. Like maybe the conventional docs aren't talking about because they don't have any idea about it.
Mm.
And we have so much knowledge in how to actually pull them back into the lifestyle and make them care about the lifestyle from this. They just sometimes need to win.
Yeah, absolutely. Well, thank you so much for joining us today. This has been eye-opening, and I'm sure it's going to be one of our most popular podcasts. It's such an important topic that is so timely. So I really appreciate your time.
Thank you for having me. Thanks.
And how can listeners learn more about you and your practice?
Yeah, so you can follow me on Instagram at drbritt.schamerhorn.nd. And then I will also be giving a virtual lecture at the AMP in July on this as well. And then, yeah, if you could follow me online, there's a couple presentations coming out.
Fabulous. Well, thank you so much, Dr. Brittany, and thank you to all of you for listening this week. I will just remind you, if you've liked this conversation and you want to learn more about hormones and really stay at the cutting edge and the forefront for women's health, men's health, hormones, adrenal, and stress, I want to make sure you are following us, subscribe to our podcast, follow us on social media at Dutch Test, and you can follow and subscribe wherever you're listening to your podcast. And make sure you tune in every Tuesday. Every Tuesday, we release a new episode. Really, this was a juicy one, and I hope to see you also next week. If you're wanting to learn and really expand your expertise in hormones, you're not going to want to miss our podcast. So make sure you tune in each and every week for our new content.